during any phase of anesthesia, starting from the induction, intubation, and all those things. Most of the anesthetic drugs are safe, but there are some anesthetic drugs which can cause arrhythmias in these periods. Even patients who undergo local anesthesia also can develop arrhythmias. Even a simple procedure like a central venous cannulation, because of stimulation of the carotid sinus reflexes, can cause bradyarrhythmias in these patients. Of course, patients who are undergoing cardiac surgery, they are at a very high risk, but there are certain non-cardiac surgeries also, like abdominal surgeries, especially laparoscopic surgeries. They can have arrhythmias in the perioperative period. So today, we can differentiate these patients into two groups: patients who have an implanted devices, patients without implantable devices. I will concentrate more on patients who have an implantable electronic devices. So today we have several devices like the pacemakers, we have the leadless pacemakers, we have the ICDs, of which we can have a conventional ICD, we can have a subcutaneous or extravascular ICDs, we have the CRT devices, we have the loop recorders. So there are several devices available in the market. Of course, apart from other things like chances of infection and all, the most important thing that we are worried about is the chance of electromagnetic interference. So EMI can occur in any of these procedures, non-cardiac procedures, especially when you are using cautery, diathermy, radio frequency, or any source of electromagnetic energy that can interfere with the function of the cardiac devices. So when you have a pacemaker, the pacemaker actually sees this electromagnetic interference as an intrinsic cardiac activity, and it will stop pacing. So the patient can have a catastrophic asystole. If he is dependent on a pacemaker, he is going to have an asystole, and it can be catastrophic. So they can have inappropriate mode switches. Some pacemakers do have a rate response, and especially when they have a vibration sensor, it will sense it as increased activity, and it can increase the heart rate of these patients. Rarely these devices can go into a complete reset, which means the programming has completely gone and you have to reprogram the device immediately. We used to see this runaway pacemaker long back. As a student, I have seen only one case, but these current generation devices, we hardly see this kind of a complication. If it is an ICD, the most important problem is inappropriate shocks. The ICD can detect this electromagnetic interference as a ventricular activity, and it will deliver a shock to the patient. And these shocks can be really painful. Patients can move during the surgery, and if you are at a critical point in the surgery, any movement in the patient movement will lead to complications. So even the subcutaneous ICDs or the extravascular ICDs that are available, they can give inappropriate shocks because of myopotential oversense. The CRT devices, we can have a combination of both pacing and ICD malfunctions. We can have a loss of pacing, we can have inappropriate shocks. Very rarely we can have a complete device reset in a CRT, which can be very catastrophic considering these patients have severe LV dysfunction. They can land up in heart failure again. The implantable loop recorders, usually they are not much of a problem in the perioperative period, but whatever data has been there, it has to be retrieved before sending the patient to surgery, because you can lose the data because of EMI. So before you take this patient, it is essential to know what kind of a device the patient has. It is not unusual today that we have several patients who do come to us that some device has been put to me. We are not sure what the device is, whether it is a pacemaker, an ICD, or a CRT, you never know. A simple palpation of the prepectoral, you can see if it is a small device, it is a pacemaker. If it is a large device, it can be an ICD or a CRT. But still, it will be prudent to know which particular kind of a device. A simple X-ray in AP and lateral views can give us the clue to what kind of a device the patient has been implanted previously. So the comprehensive strategy involves the device clinic, where the patient has been checked previously, the pre-procedure checking of the device and optimize the settings and prepare the patient for the surgery. During intra-procedural period, you have to have monitoring and emergency management and the strategies to backup strategies. And post-procedure, again, you restore the settings and see that the device is functioning normally. So you have to plan appropriately, have the checklist, kind of pacemaker. You should know the manufacturer also. I'll come to that why. You should know the indication, especially if the patient is dependent on a pacemaker, you should be very careful. Any electromagnetic interference can lead to loss of pacing, the dependency of the patient. During the pre-procedure, it is essential to interrogate, program the device, and test the magnet response of the device. Obviously, intra-procedure is about monitoring the patient and backup responses. Post-procedure, again, reprogramming the device, and if the new settings, you have to inform the device clinic. This was what I said. We know that most of us are we know that we can put a magnet and turn the pacemaker into asynchronous pacing mode. But how will the pacemaker respond to a magnet? It depends on various companies. In the sense, different devices and different manufacturers have different magnet response. So it is essential to know which particular device and the company also to know what is the appropriate response. Because if we don't know, you will not be able to tell whether the device is functioning normally or not. So a practical strategy in this patient is, if you have infra-umbilical surgery and the device is far away, you can just proceed. But if you have a supra-umbilical surgery and the device is nearby, you see whether it is a defibrillator. If it is a defibrillator, just disable the ICD therapies. And if the patient is dependent on pacing, you have to have a backup pacing therapist. If it is not a defibrillator, it's just a pacemaker. If the patient is dependent, you switch on to asynchronous pacing mode and send the patient for surgery. If he is not dependent, it is probably safe to send him without any programming. Apart from the programming of the devices, there are certain strategies that we have to use to prevent electromagnetic interference. When you are using a cautery, keep the current path away from the device, as far from the device, at least 15 centimeters away from the device. Use bipolar cautery whenever it is feasible. Whenever you're using unipolar cautery, limit to less than 5-second pulses. Avoid whole body return electrodes. Let me emphasize this. A device with a low battery increases the risk of current intrusion and increases the risk of electromagnetic interference. Keep the magnet ready and know the magnet response of various devices and various companies also. You have to have the device program always. It is advisable to keep it in the OR or near to the OR, and be ready for backup pacing, transcutaneous or transvenous. This is extremely important if the patient is dependent on pacing. If it is an ICD, apart from switching off the therapies, keep a magnet, but remember that the magnet can switch off the therapies, but it cannot go into asynchronous pacing. Backup pacing may not be available if it is an ICD. So you have to be prepared for having backup pacing strategies. When you use external defibrillation paddles, make sure that these paddles are far away from the device, at least around 7 to 8 centimeters away from the device. Especially anteroposterior paddles should be used in these patients. And leadless devices, we have quite a good number of patients with leadless pacemakers now. Remember, magnets don't work. You have to program the device prior to surgery. So these are the current guidelines that we follow. If we have a transvenous implantable device, if it is an ICD, you just have to reprogram if the patient is dependent on a pacemaker, we reprogram to a asynchronous mode and disable the ICD therapy. If not, just use a magnet. If it is just a pacemaker, if the patient is dependent, again, use a magnet or reprogram to a asynchronous mode. If the patient is not dependent, you just need to have a magnet standby and monitor the patient. Even for non-transvenous devices like a leadless pacemaker or a subcutaneous ICD, we have certain recommendation. If it is a subcutaneous ICDs, if the EMI is above the groin, it's very near to the ICD. Remember, it is a groin here because the subcutaneous ICD is much lower as compared to routine conventional ICD. You have to switch off the therapies if it is very nearby. Otherwise, if you think it is far away, no intervention is needed. For a leadless pacemaker, it is mandatory to program the device to asynchronous mode if the patient is dependent on this thing. So I will not take much time on the arrhythmias part because we can have any number of arrhythmias or almost all the arrhythmias are possible in the post-operative period. Sinus bradycardia is very common because of various reasons, hypothermia, drug effects or other things. Asymptomatic bradycardia does not require any treatment, but we have several drugs like atropine or isoprenaline or dopamine infusion can be used. AV blocks, the first degree AV block is usually safe and benign, but you have to monitor the patient to see whether this patient is going, especially if it is a new onset first degree AV block, which the patient doesn't have at baseline, it is prudent to monitor the patient. A second degree AV block, if it is a vancomycin, it is usually safe, we can just monitor the patient, but if it is a type 2 Mobitz AV block, these patients can have a high-grade AV block. You have to be prepared for a backup pacing for these patients. Of course, a third-degree AV block, again, if you have a narrow QRS escape rhythm, which is likely to be a stable escape rhythm, you can monitor the patient. But if it is a wide QRS and infrahisian disease, treat the conditions, treatable conditions, secondary conditions that we have seen, and get ready for pacing, transcutaneous, and if possible, transvenous. So we have the algorithms which have been given by the guidelines. Premature beats are very common, not required to treat normally, but beta blockade can be very effective if you need to do. A word about SVTs. SVTs are fairly common in the perioperative period. Most of them are actually pathway mediated SVTs. They are usually well tolerated. If there is no structural heart disease, patients are usually hemodynamically stable. We do have time to give IV adenosine or beta blockers in most of these patients. So of course, the one situation where you have to be aggressive is when the patient has a pre-excited atrial fibrillation, where cardioversion is the only treatment that can save the patient. Atrial tachycardias are quite common, around 6% of the patients. If the patient has a structural heart disease, again they are poorly tolerated. You can consider beta blocker or class 3 antiarrhythmics in these patients. Flutters, we can see flutters in such patients. Most of these flutters are patients with structural heart disease. We have a very rapid atrial rate, but mind you, the only problem that we are going to face is when the patient has a 1-to-1 AV conduction with a flutter. That is a situation where we have to be very aggressive and control the flutter on table. The treatment of an acute paroxysm, again, electrical cardioversion, class 3 and class 1C drugs are useful. Other things like beta blockers or calcium channel blockers can be used for rate control. AF is a frequent problem. I think among elderly patients and patients who have structural heart disease, the most common rhythm disturbance is atrial fibrillation. Many patients who undergo CIBGs and other cardiac surgeries, they have almost 60% incidence of having atrial fibrillation. Postoperative atrial fibrillation is pathologically slightly different from other forms of atrial fibrillation. Control of ventricular response is essential. Class 3 antiarrhythmic drugs are useful and effective. Amiodarone is quite safe, especially in patients with structural heart disease. In patients with structural heart disease, we cannot give class 1C antiarrhythmic drugs. And of course, if the rhythm is unstable, cardioversion is the treatment of choice. But if the patient is having chronic atrial fibrillation before he comes to the OR, probably we should not rush to give amiodarone or cardiovert the patient, because these patients may have thrombi, which can lead to systemic embolization, and it may be unlikely, it's unlikely that the patient may revert to sinus rhythm and maintain sinus rhythm. So there is no point in urgency in trying to revert the patients to sinus rhythm. You can think of a rate control strategy in these patients. Ventricular arrhythmias are equally quite common. Isolated ventricular premature beats are fairly common in the post-operative period. Usually no treatment is required, but then keep a view about these things. If there are multiple morphologies or there is an R on T phenomenon, it is these PVCs that can cause problem in the operating theater, and especially if the patient has a structural heart disease. Lidocaine is a very useful drug in this particular situation, and IV beta blockers also can be used. A word about VT, I would like to emphasize here that we have to see whether it is a monomorphic VT or a polymorphic VT, because if it is a monomorphic VT, it is most likely to be a reentrant tachycardia, where all your class 3, class 1C, everything is going to help you. But if it is a polymorphic VT, none of these things are going to help you, because apart from the substrate, there are some dynamic components like ischemia or electrolyte imbalance or inflammation that are going on. So we have to be more aggressive with a polymorphic VT. So it is essential to identify whether it is a monomorphic or a polymorphic VT. Non-sustained VTs can be monitored safely. The main strategy is prevention and instituting immediate treatment. Monitor the electrolyte levels, especially potassium and magnesium. Of course, if there is hemodynamic compromise, DC version is the only treatment of choice. Amiodarone is safe and very useful in these things. The only problem is amiodarone has a slightly delayed onset of action, so we have to load the patient immediately. Maybe a double loading dose has to be given immediately. So the administration of multiple antiarrhythmic drugs should be avoided in this particular group of patients. Of course, ventricular fibrillation is one thing. It is a catastrophe on table, and if we can if we see any kind of this thing, the only thing is think about myocardial ischemia, treat the underlying hypoxemia, electrolyte imbalance, and start the ACLS protocols. Finally, a word about the drug interactions. Several anesthetic medications can induce arrhythmias. There is a long list of these things which can be found in any standard books. There are some interactions between antiarrhythmic medications and anesthetic medications. So we have to keep in mind that these drug-drug interactions are very essential to monitor these patients in these things. So to summarize, the arrhythmias in OR is not an uncommon phenomenon. In fact, it is a fairly common phenomenon. Most of these arrhythmias are safe and benign. The most important thing is to determine whether the arrhythmia is benign, the patient is hemodynamically stable, or the patient is going to be hemodynamically unstable. Then the choice of anesthetic agents is important. Prevention is as important as treatment. Recognition of risk factors and adequate selection of drugs is essential. Electrolytes should be monitored before and after the surgery. It's mandatory. Supraventricular tachycardia usually responds with treatments like adenosine, while AF doesn't respond. Class 3 drugs like amiodarone and sotalol are very useful and safe in this particular patient, especially those patients who have a structural heart disease. Don't underestimate the use of magnesium, potassium, and adenosine in managing these patients. The management in perioperative dysrhythmias does not always include the use of antiarrhythmic drugs, which should not be delayed and should be administered as early as possible. Thank you.
Thank you, sir. Sir, we request you to stay back on the stage and join the panelists to chair the rest of the session, sir.